Yes, I think we can start. Welcome everyone to this Muthuswamy Virtual University of Postgraduate Ophthalmology mock class on Retina. So Dr. Angshuman has been a candidate from our university. He is a practicing retinal consultant at these eye hospitals, West Bengal.
Okay.
So, and he's the first candidate of Muthuswamy University who actually uh, contributed some money towards the improvement of the website, and we are grateful to him for that, and we are also grateful to him for giving his valuable time to teach our candidates. So Dr. Anshuman,
We are all grateful to you too for, for your immense energy and time and your dedication.
yes, we are trying to continue what Muthuswamy sir started, and it is a people learning exercise.
Okay. So I should start now.
Yes, please start.
So I would like the candidates to participate, please, because it will help you prepare and answer during examination. So first, I will show two fundus pictures. Can anybody describe the fundus picture and give a in, initial diagnosis? I think these are very typical pictures. I will show you four slides. So, so please go on describing the fundus first from the first picture.
Dr. Heba.
Hello.
Hello, please participate and
Yeah,
describe
I
the.
can found the photo. Yeah, okay. I can see a colored fundus photo for both eyes, in the right and left eye, showing mottled macula in both eyes, with loss of foveal reflex.
Go ahead.
Okay.
So what is happening around the fovea? Is there any change or is it normal?
No, it is mottled with loss of foveal reflex, grayish tint centrally and with grayish tint centrally on both eyes. I feel like it is. I don't know. Actually, I don't know.
Okay,
Is it ED?
can you try with this? If you have seen this, these are very common cases in the OPD. So if you can try describing these, or maybe you have seen this OCT.
Yeah. In this OCT, I can see.
Link it.
Okay, it's kind of a solar retinopathy. Hello.
Yes, the OCT can have a differential diagnosis of solar retinopathy, but there is in solar retinopathy, will you find such kind of pigmentation around the fovea?
Mm-hmm. Yes,
There are some pigments around the fovea, not exactly involving the fovea, but around the fovea there are some pigments or some crystals, etc. in this image. So what other differentials can you have?
Can you describe the OCT?
Yeah, in the OCT there is disruption of the ISOS junction, and there is also microcyst, subfoveal microcyst.
And this one?
This one there is like a scar. Okay, with back shadowing.
So Dr. Angshuman, please.
So this, if you see the in the right fundus, there is a grayish loss of translucency in the around the fovea,
Mm-hmm.
and in the both the actual it is also in the left eye also. The foveal reflex is dull, and there is loss of There is a kind of grayish film-like discoloration in both around the fovea and both the eyes. So.
Mm-hmm.
So anybody else would like to comment or diagnose this? This is quite common in OPD. Anybody else? Any of the other candidates would like to diagnose or
Sir, I
describe?
would like to comment.
Yeah, please go
There's a presence of grayish-green subretinal lesion present on foveal area associated with hypo and hyperpigmentation in both right and left eyes. So most probable diagnosis will be CNV.
But what about these are the OCT of the same patients. This is of the first picture, and this is of the second picture. These are two patients. So this is
Okay.
on the OCT picture of the first patient, this patient, and this is the OCT picture of the second patient.
So there's discontinuity in the ISOS junction.
Okay, anybody else would like to try?
That disease is bilateral symmetric, no? So are there any other thing? It is almost similar in the both the eyes, almost mirror images, no? So what can it be?
So it's kind of hereditary diseases.
Yes, it will be a differential diagnosis, but
Pathology.
the picture, perifoveal graying, donut shaped perifoveal graying, and in some cases pigmentation, foveal thinning, intraretinal cystic like or intraretinal tissue loss, ILM drape. What is the disease?
Okay, so this is actually a very typical pictures of parafoveal telangiectasia. This is MacTel type 2, macular telangiectasia type 2, which is usually bilateral and acquired in onset in adult age. So these are very typical pictures you should be able to diagnose in the OPD and the exams. These are because these are quite common cases. So this is the important clinical OCT findings. These are the cavitations and ILM drape is one important terminology finding. Over here, you are not we are not able to see that, but there is tissue loss in the fovea. This atrophic, these NSR neurosensitive, the whole of the neurosensitive tissue is atrophy across all the layers in the fovea. So what is this black? Can anybody comment on this black pigmentation? What is happening? Or what is the pathology in parafoveal telangiectasia? Does anybody remember that or know that? Hello.
Is it RPE hypertrophy?
Yeah.
As in
This is
pigmentation?
yeah, very good. Okay. RP hyperplasia is the actual terminology. So this is parafoveal telangiectasia. So anybody would, what is the management or approach to management for this patient? Can anybody comment?
And so I would counsel the patient on a poor prognosis, advise them on low vision aids and blind registration, monitoring with Amsler grids, and optimizing the health of the optic nerve, avoiding smoking and other toxic retinal drugs.
Okay, that's very good. Okay. So what is the one of the complications that can why are you saying about home ampular grid? What do you expect to happen that you are asking the patient to monitor the vision in the ampular grid?
They may have metamorphopsia from continual distortion of the macula and the fovea, and loss of central vision.
Any complications or any sequelae of this peripheral telangiectasia that might develop later on?
Choroidal neovascularization and intraretinal hemorrhage.
Okay. So do you know any other types of or the types of peripheral telangiectasia? Any other types?
There's also type 1. I believe it has a better prognosis, a slightly better prognosis, if I remember correctly.
Okay. So the important OCT findings, as you told, is cavitations and ILM drift that Dr. Kaushik Tripathi already told, and there's loss of ellipsoid and all the tissue loss. Actually, the pathology is degeneration of the molar cells and peripheral neurodegenerative change. There are many postulates. Just hold on. Dr. Kaushik, can you?
Yes, Dr. Angshuman.
Yeah, we will proceed. So these are the types. Type is one is congenital unilateral, and it's a variant of Coats disease. And type 2 is acquired and bilateral, which is most common, which we are seeing in our slides. Type 3 is primarily occlusive and is poorly understood and is very rare. So management, as Dr. Noel already told, is observation, OCT follow-up, and ampular with monitoring, and anti-VEGF if choroidal neovascular develops. And laser might have a role if there is exudation away from the if there's leakage in angiogram away from the fovea. So stages, these are the stages. If you want to read it later on in the slides. The stage 1 is actually may not be able to diagnose unless you do an FAF, fundus autofluorescence. It apparently appears normal. Stage 2 is the mild graying, loss of perifoveal translucency. As we saw in the first picture, probably that was stage 2. Stage 3 is telangiectatic vessels. We can see the right angle bend in the venules. And we can also detect the sub-ILM crystals. And stage 3, until stage 4, there is no exudation. And pigmentary changes and exudation only occur in the stage 4. And the pigments are what? RP, hyperplasia, and migration intraretinally. So pathology, what IVK says is, you can read later on, that the chronic degeneration of molar cells and parafoveal neural abnormalities. Histopathology has shown disruption of pericytes, ectatic vessels with dilated venules, diving at right angle, the deeper retinal layers, RP, hyperplasia, loss of outer nuclear layer, ellipsoid zone, with later formation of cyst-like cavitations that can encompass all retinal layers. Pathophysiology is the same, can develop retinal neovascularization temporal in the temporal aspect of the fovea and lead to exudation, which is the choroidal neovascular membrane, as Dr. Noel described. So can anybody, this is a diabetic patient. Can
Sir, Dr. Angshuman, there was a question, could this happen in post-operative repair of macular hole? This usually doesn't happen. Perifoveal graying will not happen after macular hole, but the outer retinal like hole or outer ISOA junction loss like appearance can happen in the early post-operative period, which usually resolves with time. But this kind of perifoveal graying or pigmentation and tissue loss in other area, other inner, the tissue loss is in inner retina also. It can be happen in inner, outer, anywhere, and sometimes it is just below the ILM, which is called ILM drape sign. So this is not seen in macular. This is very typical. The photos which Dr. Angshuman showed, those are very typical of macular telangiectasia type 2. So though OCT features might be a little like the differentials might be differential of outer like subfoveal ISOS junction loss or ellipsoid zone loss may be macular hole surgery immediate post-operative, but other than that there is no like similarity here.
Yeah.
Mm.
So this this is a patient of diabetes. So can anybody describe the fundus, please?
Yeah, please volunteer, anyone.
Can I share?
Yeah, please.
Okay. This is a colored fundus photo of the left eye. There is peripapillary disc hemorrhages, exudates. The fundus, the disc may show signs of papillopathy. There are circinate, well-demarcated exudates, most probably hard exudates, circumscribing the nasal part of the disc. There are also hemorrhage all over the temporal arcades and all over the retina. I think this may be proliferative retinopathy for differential diagnosis. The first comes diabetic, maybe branch vein occlusion, maybe a radiation retinopathy, or maybe due to hemoglobinopathies. Sorry, I haven't commented on the macula. The macula looks somewhat elevated, grayish in color, denoting the presence of edema. This can be confirmed by OCT. We have an OCT picture. We have cystic-like spaces in the inner retina. There is also pigment epithelial detachment. That's it. Thank you.
So why are you saying that proliferative diabetic retinopathy could be a differential?
Because you have told that this is a diabetic patient.
But are you able to appreciate any obvious neovascularization or?
It's not the picture.
Pardon? It's not a.
Not a classic picture.
Not a classic, but it is more of a looks more of a like a non-proliferative, isn't it? Fundus picture, isn't it? So we are not able to see any new vessel anywhere on the disc, neither in or any elsewhere. So it goes more for non-proliferative. So I said that this is a diabetic patient. So the diagnosis you told as you said non-proliferative diabetic retinopathy with exudative maculopathy in the right eye. So can you elaborate on the management of this patient?
Okay. First of all, I should take a good history from the patient. I should recall his diabetic control, HbA1c, shouldn't exceed 6.5 millimole. I should ask for his lipid profile, his blood pressure, and his renal functions. I should ask about smoking. I should send him to an internist. Also, I should I should take history of the duration of his diabetes and the control within this duration. Then starting to examine his visual acuity, anterior segment, searching for any signs of neovascularization or atrophy. Then I should ask about. Then I should search. Then I should examine the fundus briefly and examining the other eye. I should send him for fluorescein angiography and OCT. I will check his renal function first before fluorescein angiography. Then after the investigations appear, I will work about according to his investigations that appeared.
Okay. So what you missed about in the history, you can also ask about presence of anemia or hemoglobin is also an important aspect you should address. If the patient is anemia, that exacerbates diabetic retinopathy. So one more important aspect is his hemoglobin percentage, and also you should inquire about intake of oral hypoglycemic agents like pioglitazones. That those are also called increases macular edema. So these two are I think important history you should not miss in your clinic. And regarding treatment, what do you suggest regarding the treatment for the patient? This is the OCT picture of the right.
Regarding treatment of this patient, according to this OCT, I should starting bevacizumab or ranibizumab.
Okay. Any
third for 1 month duration for 3 consecutive.
Hello.
Sorry.
Your voice is breaking at times. Okay, go ahead.
Hello.
Hello. Yeah, continue, please.
Okay. I'll start for 3 consecutive injections of anti-VEGF, then reassess the condition of the macula and the condition of the edema. If it regressed, then I will continue to follow up the patient. I should proceed with fluorescein to elicit if parts of ischemia or if there is a recent neovascularization. Every 3 months, then every 6 months.
Okay. So, Dr. Kaushik, do you have anything to add?
No, basically, systemic control should be first. Like, if whatever you tell, you just say that I'll control diabetes and hypertension and the other systemic diseases, including nephropathy, hyperlipidemia, etc. So those should be the first stage. Do not go jump directly to anti-VEGF because that will create problem. So if it is a diabetic patient, you need to control the patient systemically, and then you proceed for ocular management. So that is what examiners will expect from you, that systemic control would be first.
Okay.
So any particular drug you would like to, suppose this patient has got a hypercholesterolemia. So any particular drug you would like to add in his drug regime?
Sorry, I can't.
For cholesterol, any anti-cholesterol drugs that helps in.
Hello.
Hello, are you able to hear? Hello.
Yes,
Yeah,
you
yeah.
are.
I mean, sorry, I don't know.
And
I don't know.
okay, you heard about the drug fenofibrate?
I don't know.
Okay. So that is supposed to, literature has suggest there is literature on phenylfibrate, which is saying that it is helping in reducing the exudative maculopathy in case of diabetic patients. So that is an added information you can have. So any studies or any guidelines you know about treatment or name of any guidelines if we follow any studies or guidelines you can name in the treatment of macular edema? Can anybody else try there are any protocols or something that laid down principles and for the treatment of diabetic macular edema?
So has anyone heard of ETDRS study? These are important studies if you understand going for exam, you need to know.
Actually, in Kansky, you should read very thoroughly because they will ask you everything. You can ask anything from Kansky. So even Kansky, the latest Kansky, you should read very thoroughly all the studies and all. Because the treatment regimen for these injections, they follow certain guidelines laid down by any what do you say? Then is association or some retina specialist. Do you know that? Have you heard about anybody heard about protocol drcr.net? Anything? Okay, so one should read Kansky is very important for your. All these are given in Kansky.
Basically, I would say the preparation of this batch is very bad. So you need to improve because if you like stay blank like this will be difficult. The basic protocols and A must be known. At least the full form of DRCR and what they have shown. At
Actually,
least read the Kansky newest version of Kansky must be read. Dr. Angshuman, please.
actually, you have to utter these words. Actually, at least you have to utter these drcr.net protocols, protocol I, protocol S, protocol T. You have to utter these some from your mouth. So these are, they can ask you that which are the guidelines that have established this treatment regimen. So they can ask you. So all these are given in Kansky. So you have to read actually Kansky thoroughly. So DRCR full form you should know. Diabetic Retinal Clinical Research Network. There is, am I right, Dr. Kaushik? Isn't it? Okay. And
Yes,
protocol.
yes, yes. Even if you do not like remember the names like protocol IES, but you should know what they had shown, like what DRCS studies have had shown. Like if you remember ranibizumab is better than laser, that is also okay.
That is, yeah, that is
Ah,
what you may forget about the protocols, but you should when you are attending conferences, they are always saying discussing about this. So you should know actually the Kansky part. You should know these are all taken from Kansky, and no information is from from any other book. So except that IVK part, everything is there in Kansky. So protocol I is saying ranibizumab is better than laser. Any other drug, anti-VEGF, you know? Any of the candidates, please?
Yes, sir.
Accept.
Yes, sir.
Aflibercept, okay. So aflibercept, protocol T is saying aflibercept is same as almost similar, early acting as ranibizumab at 5 years, but visual acuity gain is better than bevacizumab. So recommendations of that are given, center involving diabetic clinically significant macular edema. When the vision is greater than 6/15, any anti-VEGF would work good, or you can go for subthreshold laser. another option. But when the CSOM is get in the vision is less than 6/15, aflibercept, yeah, and or faricimab is nowadays they are suggesting faricimab as a better drug, though results or long-term clinical experience is yet to, I think, be established. These are the two newer. Faricimab is a newer drug. Brolucizumab. You heard about brolucizumab? I think all of you.
Yes, sir.
Okay. So the dose regimen is 6 monthly injection of 3 to not. It's not 3 is usually followed most of the countries. The actually recommendation is you can go for 3 to 6 months. Then you can switch over to P. What is PRN? Anybody? I think you all know. What is PRN?
This you'll have to tell. One candidate
As
will tell.
needed.
Hmm.
Bririnata. Bririnata.
Meaning?
Bririnata as needed. It means as
Yes,
needed.
as needed.
Okay.
Prorinat.
Prorinat. Prorinat. Okay.
Bririnata. Okay.
So Ozurdex, what is the Ozurdex? I think you all have heard about Ozurdex.
Yes, sir.
Okay. So what? When is the any study you know about the Ozurdex? Yeah. Ozurdex studies for diabetic macular edema. Any other steroid implant you know? Anybody? Okay, these are the others. The Ozurdex, there is a meat study. The amount we inject is 0.7 milligram. Anybody, what is the amount we are injecting in ranibizumab and bevacizumab? They can ask. Can anybody say that? Ranibizumab, dosage of ranibizumab and
So ranibizumab, I think it's 0.5 milligram.
bevacizumab.
It's 1.25 milligram.
Okay, very good. Okay, and Ozurdex is 0.7 milligram. Iluvien, what is Iluvien? Anybody?
So it's a slow releasing the steroid implant.
What is this?
Fluocinolone.
Yeah, fluocinolone. Yeah, very good. Okay. So, what is the diagnosis for this patient? Can please describe and mention the diagnosis? Anybody of any candidate, please.
First, tell what is the imaging modality. Which in the left side, what is the machine which has been used? Any candidate? Well, request all candidates to please prepare and then come to mock exam. Otherwise, it is a wastage of time and efforts. And Dr.
This
Charlie,
is a colored fundus photo of on OCT wide field.
no, it is the color fundus photo, but it is the view is a little large, no? Is normal does normal color fundus photo show this thing? Like this is
Field of view is quite large, isn't it? So,
Yes, a
what
wide
would be
field.
the imaging modality?
Optus. Wide field.
Yeah.
Yes, and also this is not color image, this is pseudo color image. So for color image, you need to put white light and the picture is taken. So this is not, these are the like scanning laser ophthalmoscope images. So this is not really a color image.
Okay.
Please continue.
And on the right, there's a picture of the OCT in cross section showing a thickened retina and edematous retina. And anterior segment, OCT angiogram, I believe at the top left, showing some hyperperfusion to the right inferior portion. I'm not sure, I'm not seeing a clear image on the right.
Okay. Dr. Kaushik, you have to add anything?
No, I think like what did you tell, doctor? What are the findings in fundus photo and OCT?
Yes. The OCT showed a thickened edematous retinal
Yes.
with an epiretinal membrane.
Yeah, I missed that. Yeah. Okay.
And what did the fundus photo show?
An obscure disc and
Yes.
some areas of
Due
hyperpigmentation.
The obscuration is due to?
Edema of the retina and
No,
possibly.
how will edema obscure that disc? So what is blocking the disc? Why do you not see the disc? What is happening here?
There could be a fibrovascular membrane
certain things are floating in the vitreous. What are they?
Oh, there's an intragel hemorrhage as well.
So what do you comment about this picture?
Okay, so it's possibly due to proliferative disease with
Hello? Hello? Dr. Kaushik?
Yes, her connection got off, I think.
Hello?
Yeah.
Yes. You are not audible. Please tell us. Like what? How could
Sorry.
where from the vitreous hemorrhage could come? What is the cause of this?
It may be due to fibroproliferative disease on the surface of the retina, resulting in vitreous hemorrhage and traction at the macula.
I have written that in the top left corner it is diabetic patient.
Okay. So diabetic fibroproliferative retinopathy with vitreous hemorrhage.
Proliferative retinopathy, okay, with vitreous hemorrhage. And do you see some other marks, spots in the retina?
I see some hyperpigmented lines and dots as well to the inferior right quadrant.
No, which eye is this? Right eye or left eye?
I can't tell from the image.
So what is there on the right side and upper side of the fundus photo? Right side and upper side of fundus photo. There are some black, white line, black dots. Or
that may be panretinal photocoagulation scars.
okay.
So anybody would like to comment on the? Anybody else would like to comment on this picture, Optos picture?
So it is a laser ophthalmoscopy photo showing a fibrovascular membrane extending from the disc, denoting that there are NVDs causing the vitreous hemorrhage, and also there is a marks of BRV, and this is right eye. This is right eye, yes. So this in the upper nasal retina, appearing is upper nasal side.
Okay, this is the right eye. You should the disc is the fovea is temporal to the disc. That's on the right side. So how do you know that this is the right eye?
I can see the arcades.
Okay. Dr. Vandana, would you like to comment? Okay. So what would be the management of this patient? This patient had a recurrent vitreous hemorrhage, and he has also an epiretinal membrane in OCT. He had been lasered some time back, and he is developing recurrent vitreous hemorrhage. What would be his management?
So this is a high risk BDR with tractional with traction on the vitreous hemorrhage and traction on the retina. So I'll take a history of this, how much time since this vitreous hemorrhage occurred. If it's type 1 diabetes, I can wait for 1 month, and if it's type 2, I can wait for 3 months. Then I can go for vitrectomy.
Okay.
Done a vitrectomy.
And what would be the I told what would be the this thing components of diabetic vitrectomy? Can you answer that? Because this question is being asked many times in FRCs. What are the components of diabetic vitrectomy?
Components?
What are the principles of diabetic vitrectomy? Okay, tell me how do you do pan-retinal photocoagulation?
Okay. Pan-retinal photocoagulation, I can do it on argon by argon laser using either BAMF endoscopic lens or sorry, I can't remember the names of other lenses. I can use this. I need to make a burn 400 micron.
Okay.
So I'll use the spot size in BAMF endoscopic lens. I'll use the spot size of 200 micron to make the burn of this size. And okay.
Which quadrant do you laser first? And
I'll first starting inferiorly. So then to protect the to target the inferior retina before bleeding. Okay. I'll delineate the borders of them outside the disc nasally to the disc, half disc diameter, and temporally to the fovea, 2 disc diameter, and outside the arcade. So I'll do my boundaries, and after that I'll start to do laser marks. It's spaced by 1 spot size in case of type 1 diabetes, and 2 spot size in case of sorry, it is only spaced by 1 spot size, as this is BDR, not severe non-BDR.
Does that have a bearing that the spot size, does it differ in case of severe PDR or non-severe?
Yeah, spacing in severe PDR, we can do spacing by 2 burns.
Okay, the number of burns, you are reducing the total number of burns. Okay.
From 3,000 to 7,000.
Okay. So, how many you do it at one go, or how many sittings?
I can divide it to 2 or 3 settings.
Okay. And any what are the risks of excessive pan-retinal photocoagulation? What will you explain to the patient before pan-retinal photocoagulation?
Yeah, I'll explain to the patient that there will be diminution in night vision after this BRB, and constricted of visual field, loss of contrast, loss of diminution of contrast vision.
And does PRP also cause increase of macular edema?
Yeah, there may be also increase in macular edema.
So you have to tell that there will be a drop in vision to the patient also. So we may have to continue with the repeat the anti-VEGF again. So so what if you go you know about anything about diabetic vitrectomy? What are the indications in case of diabetic vitrectomy?
And diabetic persistent vitreous hemorrhage, 1 month for type 1 diabetes, or 3 months for type 2 diabetes, and tractional or rheumatogenic retinal detachment. Also epiretinal membrane, epiretinal hemorrhage, macular hemorrhage or premacular hemorrhage that doesn't resolve.
Okay. Dr. Kaushik, are you there? So component.
Yes, yes, I am there. I think the all that like for PPV in diabetes mellitus, the implications should be known by all. These are very common question and everybody must know.
So what are the lenses used for PRP? Pan-fundoscopic lenses, Mainster and Goldman 3 mirror. One should know the names actually. These are, you should know that they can ask you the type of lenses used. And protocol ACE. Does anybody know about anything about this? Okay. So protocol ACE is a new concept that the course of randomization is same as PRP at 5 years in high risk PDR. This is what protocol ACE is claiming to as an outcome of instead of PRP, one can do ranibizumab. Course of ranibizumab, the results are same. But in clinical practice, I don't think we are doing only ranibizumab in case of proliferative diabetic retinopathy. So this is a clarity study, which is a similar study with aflibercept, which is saying aflibercept is similar, having similar outcome as PRP. So methods of PRP laser are spot size, as Dr. Loin, I think Loin said, right, 400 microns. Correction factor is 2 into spot sizes in case of pan-fundoscopic. Mainster is approximately the same as the spot size in the laser console. And pattern of laser, doctors said that inferior part is done first, because if vitreous hemorrhage develops, it gravitates in the inferior part, so one can miss later if vitreous hemorrhage happens. So you may not do the inferior part later. You may not be able to do the inferior part. You can also do a barrier laser temporal to the macula, so it helps in delineation and helps in delineation of the laser border, so you don't damage the macula if the media is hazy. And duration may be asked. You should know that it's 10 to 50 milliseconds, and burn intensity should be light intensity burn. So steps of diabetic vitrectomy. These are the question one of my examiners asked me. So you should know. After making 3 ports, so triamcinolone assisted vitrectomy, plus one can do careful base dissection. May not be done always. These are the things you should be able to utter, at least bring out from your mouth. So the segmentation and delamination in block dissection, membrane removal, then hemostasis. The vitrectomy laser, diabetic vitrectomy should always has to end with hemostasis. And if you need to do cautery to burn the bleeders, then you finish the laser photocoagulation. These are the steps you have to say, because otherwise this, if you say this much or these three words only, it will be enough. And gas or silicone oil tamponade. So next is my next picture. Anybody would like to volunteer, please? Dr. Heba?
Hello.
Yeah. Can you volunteer for this fundus picture?
Okay. There's a colored photo for right eye.
Yeah.
Showing okay. Showing that the disc is I can see that the media all over is slightly haze, but there is some I don't know, it is intraretinal or intraretinal hemorrhage scattered temporal to the fovea, inferior temporally, and the temporal to the fovea. And also with loss of the fovea reflex with grayish discoloration surrounding the fovea, denoting some edema, some macular edema.
What is your diagnosis?
So it is a cases of macular edema for differential diagnosis.
Macular edema secondary to what? What are these hemorrhages denoting? The inferior temporal?
It may be branch retinal vein occlusion.
Okay. So you should be able to diagnose this for this picture, actually. So what is your management for this patient?
My management, first I'll take a good history about this patient, diabetes, the diabetic state, hypertension, lipid hyperlipidemia state, and after that I'll go for investigations, lipid profile, blood pressure.
Suppose this patient has come to your clinic. What will you do at first?
Okay. I'll ask for CBC, for blood pressure, for lipid profile, fasting blood sugar, and hemoglobin A1C, and the 2-hour postprandial. Also, I'll working in collaboration with the internist or cardiologist for control the systemic risk factors like diabetes and hypertension. And if this patient is young in age, I can ask for more investigations. Okay. In my clinic also, I have to take after good history. I have to examine the patient visual acuity, do relative afferent papillary defect, measure the IOP, and also examine the anterior segments, examine the iris well for any new vessels, examine the angle, examine the lens for cataract, and after that go to the vitreous, examine for any signs of vitreous hemorrhage, posterior segment.
In this patient, you don't see. Okay, you need to.
And I have to examine the other eye.
Okay, so what will be your management for this patient? Management treatment.
in this patient. According to vision, this patient vision is more than 6/9. I can observe this patient after controlling systemic risk factors.
Suppose his vision is less than 6/9, 6/36 or 10/34.
Actually, with the thickness of the retina, I can wait. I cannot go for injection as the retinal thickness in OCT is not too high.
Okay.
I can observe the patient first.
Yeah, okay. Once if he develops a drop in vision, suppose he develops a drop in vision, you will go for anti-VEGF.
Yeah.
What are the treatment options you know about for BRVO?
Other treatment options rather than anti-VEGF, other drugs. Yeah, intravitreal steroids implant.
You can do an angiogram also, isn't it?
I can do fluorescein angiogram to denote the areas of capillary dropouts and to know if there is ischemia.
Okay. Okay. Any other treatment modality that was present before the onset of anti-VEGF? Before anti-VEGF was
non-steroidal.
before anti-VEGF was available, what treatment was done for BRVO?
Focal grade laser.
You have to
Right.
read about it. You can mention those things.
Yeah.
So what is the? Can anybody else volunteer for what is the basic difference in pathology for BRVO and retinal vein occlusions and retinal arterial occlusions? What is the basic difference in pathology?
In CRVO, there is more of ischemic element, and in BRVO, there is venous stasis. There is perfusion, but there is venous stasis.
What causes BRVO and what causes CRVO?
I think in BRVOs because of arteriosclerosis and CRAs because of atherosclerosis.
What is arteriosclerosis and what is atherosclerosis?
Arteriosclerosis is the thickening of the wall of the arteries which causes vein occlusion, and atherosclerosis is the presence of the plaque which causes obstruction in the artery.
So BRVO is what happens in BRVO?
I think this in central retinal artery, this is most probably embolic, but in vein, this most probably is thrombotic.
Yeah, that's what I'm asking. BRVO venous occlusion is usually thrombotic, so local pathology, and what arterial occlusions are can be local pathology like you said, atherosclerotic or atherosclerotic local constriction, and mostly embolus also. So something is most present more proximally, that some turbulence or some cholesterol or some endocarditis, some plaque like that has got dislodged and migrated to the ophthalmic circulation and causing occlusion. So PRVO is basically thrombotic and arterial occlusion is basically embolic. So you have to utter these words: thrombosis and emboli. So what are the emboli you know about? Do you know about this given in Kansky? Name of emboli. They can give you a picture of a CRO kind of. They usually give a picture, a very clear-cut picture of CRO with some sort of findings, some sort of emboli. So what are the names of the emboli? Do you know?
There is the Holland-Horst embolus, and I can't remember the other name actually.
It's actually not
Calcific. and fibrin clots.
So, remember names like Hollenhorst plaque. I was given a picture. They asked me this question. What do you see there? So this fibrin platelet plaque. In the picture, you may not, because you are tense, you may not be able to utter these things. So you should know Hollenhorst plaque, fibrin platelet plaque, or called calcific embolus. So these CRO picture is quite common in the first exam. So this is another. So these are some studies you should know. BRVO studies. Minimum you should actually know other than the BRVO study. What are the recommendations or findings of BRVO study? Can anybody elaborate? What are they? Or what did they discuss about? What was the outcome of BRVO study? Recent guidelines. I'm meaning to say this one. Lower the other trials. Can anybody discuss about the BRVO studies? Or CRVO study? Anybody? Dr. Kaushik, you are there?
Yes, yes, I am there. I feel the preparation of the candidates are not like, I think it is a like, people should read more and then come for classes. Otherwise, like this is, if there is no interaction, then it is very difficult to continue.
So so once you should read at least BRVO and CRVO studies, and for BRVO you should. It is given all in Kansky to help you remember the Bravo and Vibrant. You should remember these are all from Kansky. And for CRVO, you should know the CRVO study, and it's all C for Cruz and Copernicus. You should remember this. All from Kansky. Geneva for Ozurdex, core study for Transferon. So what are the, can anybody discuss indications of laser in CRVO?
Yes, sir.
Can anybody please go ahead?
For rubeotic rubeosis iridis, new vessels in the angles, or ischemic CRVO with proliferative disease, or acentral edema, focal laser.
CRVO, focal laser.
Yeah.
No.
Sorry, not the
Why do
CRVO.
you laser? Focal laser means a single focus, no single spot. So why do you put the spot in BRVO if you want to do a focal laser?
In BRVO.
What is a better term? Is it focal laser or something else?
Scatter laser.
What laser?
Scatter.
Scatter laser.
Scatter laser, yes, scatter laser can be done for new vessels. BRVO with new vessels, but we are talking about macular edema. So for macular edema, in
Grid laser.
BRVO, what kind of laser do you do? Is it focal
Grid laser.
What?
For central macular edema, grid laser.
Yes, grid laser, grid laser. The answer would be grid. So the names are very important. If you say focal laser, then it will be, it is not focal laser, because in focal laser, you will just laser a specific point of focus. But in BRVO, it is usually an area. So that is where you will do grid laser, but most of the times we are not using that. So
in CRVO, actually, the grid laser is not indicated. CRVO only of the CRVO study is that the new vessel develops in the iris. Only indication is treatment recommendation is that, and otherwise anti-VEGFs are usually given in the initial stages. And BRVO for initially anti-VEGF, then in case of recalcitrant or non-responding venous occlusions, you can go for grid laser. Then these are these studies from this thing, Kansky. You must read about this. So, what is the diagnosis for this? Just what is the diagnosis, PVR and management, PVR grade and management? Anybody? This is very simple, I think, question. Can anybody answer this?
Can I share?
Hey, please go ahead with.
Okay. In the left eye, there is two upper horseshoe tears. Sorry, the colored fundus photo. We using stereoscopic laser ophthalmic technique. Okay. There is a wide field variety. Uh, I can see two horseshoe tears in the upper temporal and the upper nasal quadrants. The upper nasal one, sorry, the upper temporal one can have proliferations or traction. There is also, I can see subretinal fluid, but it's more prominent in the right eye. There is bullous RD in the right eye.
These are the
Okay.
right, one eye only, same eye, same eye.
Okay. I can see subretinal fluid filling the I think most of the quadrants. I think so. The macula is off. That's it. This is all what I can see.
So, what is your diagnosis? You showed horseshoe tear, macula is off. So, what is your diagnosis?
This is retinal detachment, total retinal detachment with macula off.
Okay. And what is the what type of retinal detachment?
Bullous retinal detachment, I think. Sorry, it's a rhegmatogenous one, rhegmatogenous retinal detachment.
And what is there are a few striations and fiber thread-like things in between the two horseshoe tears. There's this kind of filmy retina. There's a linear striations kind of retina, striate kind of retina. There's a linear band-like thing with intervening striate kind of picture. What
You
is
mean fish mouthing?
no. In between the two horseshoe tears, you, in the superior quadrant, you will see the area of thin retina with striations, certain linear marks on that, linear striate kind of appearance.
Are these lattice degenerations? I don't know.
Yeah, right.
Lattice.
So, is this a total retinal detachment or?
It takes the whole the two upper quadrants, the lower temporal quadrant, sparing the lower nasal only.
Okay. So, lower inferior quadrant is spared. Most of the superior retina is detached. And
Okay.
what is the PVR grade?
Actually, I don't know.
Okay, you should read the PVR grade, PVR grading from your book, from Kansky only, it's enough. And what is this? Do you know about this PVR grade? Can you comment on this PVR grade?
I haven't read the grading of PRV before. I'm sorry.
Anybody else? Okay. So these are this is actual PVR grade B. Once there are star-like retinal folds develop, so then PV, you call it PVRC. The top, you correctly identify the lattice degeneration is there, and the rolled edges of the horseshoe tears are there. The horseshoe tear edges are rolled kind of thing. So this is a PVR grade B, and you have missed by it's easy to miss. There is a macular hole also in this detachment. I think the macula there has also developed a hole. And in this this is an inferior retinal detachment with star-like folds. Can you identify the star-like folds over here in the right picture, just above the horseshoe tear? It is star-like. The retina has developed star-like contractions. Can you hear
Okay.
me? So
Yeah.
these are called these are present in grade PVR grade C. These are actually in this picture it is not clear. He has more than 2 or 3 star folds. One is in the right in the center of the picture. One is there. So when there is PVR when there is star fold has appeared, it is PVR grade C. And when the PVR grade D, C, and the newer nomenclature, you must read about the newer nomenclature and the older nomenclature as well. The Kansky is enough to know about the PVR grades. So
Okay.
management, what would do? How do you manage this patient? Say this patient.
First of all, I should take a brief history um about any incident of trauma, um, history of asking about also the other eye, asking for any family history of the same case. I should examine the anterior segment. I should search for other holes or tears that are missing. Um, um, I should examine the visual acuity to ensure the case if the macula is on and off, to ensure I should do relative afferent pupillary defect. Um,
Suppose this patient has come to your clinic. What
Mhm.
after you have seen what are the most important things you do? You see the
um,
vision, isn't it?
Vision, yeah, vision
It-
and the sorry, and the relative afferent pupillary defect.
and you ask about the duration of detachment. Isn't
Okay, yeah,
ask
yeah.
about duration, vision. Also see the other eye for any degeneration kind of thing, lattice degeneration kind of thing. You see also see the other eye for any degeneration or any tears. You have to save if there is a degeneration in the other eye or a tear in that other, you have to do a laser to save the eye, that retina eye from getting detached. And for this patient needs a what observation or medicines or surgery.
No, I think if it is a recent detachment, he needs urgent surgery.
Okay. So what surgery do you, do you call it?
Mm.
What is the name of the surgery?
I will perform a partial vitrectomy, plus air or gas or silicone injection.
Silicone oil. Okay. Anybody else would like to add anything? Dr. Kaushik?
Yes, I think classification of PVR, like there are 2 or 3 classifications all of us should know about this, and definitely know about the like basics of management. Like when do you want to do scleral buckling, when do you want to do pneumatic retinopexy, and when we should go for personal vitrectomy, that should be known. And also the indications of treatment for symptomatic PVD with tear, lattices, So these are the other things which we need to read, like if a patient comes with symptomatic deformity, how we have to proceed.
So the examining the other eye is also very important in case of any patient with any detachment in one eye. It's very important to examine the other eye also, because he or she might have a lattice or a tear in that eye also. You have to protect that eye by laser. And so this patient also needs, is, as you said, vitrectomy with silicone oil tamponade. And also one more addition is sometime one more procedure is sometimes done in retinal detachment. Do you know anything? Can you guess what is that? Retinal detachment surgery? Anybody?
Um,
One
is it
more.
a remnant of a
Pardon?
scleral buckle?
Other than scleral buckle combined with vitrectomy. Any other material is put around the eye?
The DACE procedure,
What? Pardon?
DACE procedure,
Encirclage.
drainage.
Procedure. Vitrectomy is internal drainage, but SRF drainage is you're probably saying about the scleral buckle. So I will move on to the next patient. This is a 20 years old male with 6/12 vision in one eye and 6 in the other eye. He has drop in vision for 5 to 6 days. This is his OCT. What is your diagnosis? Anybody, please?
The mock exam, please volunteer.
Yes, sir.
Can I share?
Can I share?
Pardon? Can you see they want to see the next picture? This is from Optos image. This is OCT image.
I think this is OCT of high myopic patient.
Pardon?
So high myopic patient. And I think there is total separation of the retinal layers.
Anybody else would like to comment, please? 28 people are there attending. No, 14.
Sir,
Yes, please.
well, I see there is a OCT picture showing sensory retinal detachment.
Okay. And this is his Optos image. What do you see?
I see inferior break,
Okay.
right eye, showing there is some inferior break.
Yeah. So what is your management or treatment? Go ahead with what is your treatment for this patient?
Well, I will refer to the VR surgeon, of course.
Refer to. Okay, so okay, but you cannot say that in your exam, isn't it?
Yeah. Well, he is young, and probably he, as it is inferior detachment, a drainage of the subretinal fluid with encircling band buckle, I mean.
Yeah. Why only inferior? And what are the indications of scleral buckle surgery? Do you know? Where scleral buckle? Where do we prefer scleral buckle surgery?
Well, in young patients and complicated detachment with PVR.
We need retinal dialysis.
No, actually scleral buckle is tried in uncomplicated detachment. So complicated, these are PVR. So you have to do.
And in addition to PPV, I mean,
Yeah,
complicated. In
you can-
addition to PPV,
scleral buckle, but in case of, as you said, young people, young patients, and
yeah,
this is what kind of detachment? This is a neurosensory detachment. These are bullous detachments, isn't it?
yeah, yes,
Bullous detachment. This is a shallow detachment.
shallow detachment.
This is one of the indications of young patient shallow detachment, shallow or non-bullous detachment. These are, or inferior breaks. These are classic indications of scleral buckle.
Okay.
Because in case of bullous RD, usually you have to drain a lot of fluid, so it becomes, and also these are kind of complicated retinal detachments, a lot of PVR. You cannot do just scleral buckle.
Yes, PPV is.
PPV is the primary procedure. Then you can add. Then you can think of adding buckle or encirclage if it is required. If you are confident with it. So this is a indication of scleral buckle. One indication of scleral buckle which I wanted to show you. And so what is this? Can anybody describe and identify this picture? Describe and diagnose this picture. Anybody would please volunteer? This picture can be given, this kind of picture. These are important cases.
Dr. Angshuman, if nobody is able to answer this, just keep this question for discussion in the group. Because it is no point like teaching people who do not know. It will not stay with them. So let them give them the image. You can like let them read and then discuss, because otherwise it will be like a single directional, like you will be saying and they'll be listening and they'll forget. So this is a typical classical finding of something.
Yeah.
So if you do not know, you can take a snapshot of this and then read and then post in the group. Otherwise, like just telling this is this may not be staying in your brain for a long time.
Yeah.
Can I try?
Yeah, please.
Yes, Dr. Charlene.
Okay, the picture on the left shows exudation of the retina right of the nerve in the right eye, and what looks like proliferative membranes over the exudation. The area of exudation is not involved in the macula. It's about 6 to 7 diameters in width by 4 diameters in height. And on the second image on the right, there appears to be intraretinal hyperpigmentation beneath the superior temporal arcade, surrounded by a circinate exudation as well around that arcade in that quadrant. The macula appears to be normal as well in this picture. Both discs are also normal. My differentials would include an exudative type of retinopathy such as Coats disease or vasculitis, secondary to BRVO.
Is Coats disease bilateral?
It could be, yes. It could be.
Could be, but is it usually bilateral?
No.
And what are the features of Coats disease present here?
And the extensive exudation.
So is it exudation or retinal whitening? Like are these hard exudates or retina is whited?
It may be retinal whitening because it seems to be below the
So
vascular arcade.
this is retinal whitening and there is hemorrhage. Then what would be the
Yes.
diagnosis? If it is not hard exudate, it is retinal whitening, then how would your differential diagnosis change?
This is an intraretinal pathology involving the lower layers of the retina, such as a macular.
What causes retinal whitening?
Ischemia and scarring.
What kind of inflammation causes retinal whitening?
Necrosis, which can cause necrosis, can cause whitening.
Yes. What thing can cause necrosis?
It can be
virus,
like CMV, retinal, because pizza.
This hemorrhage kind, this whitening will happen. So this is specifically in the right eye. This is very typical of CMV retinitis. You need to see the images and then so if such a thing, similar patient comes, you have to look for HIV and you need to rule out CMV retinitis in such a case. And left eye is actually healing. This is old episode in the left eye.
Yeah.
Dr. Please elaborate. Most likely patient is on highly active anti-retinal therapy.
Yes. This patient, this picture, you should be able. This is a what I say, a sure shot diagnosis of CMV retinitis by the fundus picture. So you should not miss this kind of pictures. He has good vision. This is adult male, 33 years. Coming history of with floaters mainly. One eye has dimness of vision by slide. So what do you go? Suppose this is diagnosis of CMV retinitis. How do you proceed with the management?
I will place them on highly antiretroviral treatment, active antiretroviral treatment after determining.
Yes, presented you with for the first time. What do you do with? This patient has come to you for the first time with this kind of clinical picture, fundus picture. What do you do for this patient?
I will take a full history with respect to any systemic illnesses, viruses, or immunocompromise, any extended hospital admissions or ICU admissions. I will take a viral load and a CD4 count. I will assess for any drug history, any personal drug history and allergies. And on examination, look for any other signs of immunocompromise in the anterior segment. And also do an OCT to determine the level of
what are the signs of immunocompromise in anterior segment? You said signs of immunocompromise in anterior segment. What are the signs?
Anterior uveitis, scleritis.
So I don't think those are signs
hypopia.
of immunocompromise.
Only an
immunocompromise, there will be no inflammation.
Only
as you see, though there is retinitis, the vitreitis is minimal because the immune response of the system is reduced. So that's what differentiates CMV retinitis from acute retinal necrosis. See, in CMV retinitis, because the immunity is low, vitreitis is typically low, or not there. See the clarity of the media. It is very clear. And if it was acute retinal necrosis, it would have, in a immunocompetent patient, it would be very hazy. So if you say that the signs of immunocompromise is anterior uveitis, scleritis, I don't think we can put it that way.
Okay.
Yes, Dr. Angshuman.
So you didn't ask for a sexual exposure for these patients.
Yes.
You did mention about sexual exposure, drug history,
Mhm.
like and you did mention about serology profile. You should for HIV and all, and CD4 count you mentioned,
Yeah.
and any other. Also, actually, ideally, you should refer to this patient to a infectious intern.
Disease special.
Infectious control center or lies with a internist for to rule out other sexual transmitted disease. Also, contact tracing is important in these kinds of patients. So you have to refer this patient to a internist for starting of antiretroviral therapy. And also, what you can, as a ophthalmologist, one can, if you can diagnose this patient, you yourself can start what drug?
Cidofovir.
Cidofovir. How will you start cidofovir?
And valcyclovir.
Valcyclovir or a little bit different name, drug with a different.
Valganciclovir or Jancyclovir.
Yeah. So actually, you should valganciclovir is the prodrug of ganciclovir.
Yes.
So it is available in the medical stores, or I don't know in other countries, but in medical with prescription, you can have a valganciclovir can be purchased, which can be taken orally, and it is very easy to prescribe, and also for the patient, it's easy for a drug regimen. So at least one drug you should be able to say is valganciclovir. Others are cidofovir is not. I don't think it's IV or intravitreal. Ganciclovir also IV. These are little complicated regimen. So easiest regimen you should remember is valganciclovir.
It's given in the loading dose of in the 900 milligram BD, and then single dose of.
BD for 3 weeks, then go switch over to OD dosing till then continue. I think till the CD4. I don't exactly have to check. Till the CD4 count I think improves. CD4 count gets beyond 100 or something. Improves better than 100. So you have to start this patient both on antiretroviral and valganciclovir. You can do it by yourself. And this thing, these patients often have co-infection with syphilis. So your internist might have to rule out infection with syphilis and all. So they have to read very thoroughly. CMV retinitis is an important clinical question, I think, in the first years. And I won't discuss this. Discuss. So can Dr. Kaushik, should I go on? Can anybody this thing?
I think just discuss that, just say the diagnosis and move on so that people can read. Just take a spot diagnosis and do not discuss because it's already 9. And let them read. And if they want classes again, we can do classes again. But I think the preparation overall was not good this time. So it is like the exam is a very costly affair, and I think we should give our best try in the exam. But the preparation is not getting reflected here. So that is sorry state here. But I think definitely we can improve. And we already know the most common questions that are being asked. So we need to be prepared, and you need to see the images, specifically the people who are not practicing retina. You cannot refer them to retina colleague. You have to know how to manage. Then you can say that I will collaborate with the retina colleague to manage this patient. But do not say that I will refer them to retina person. So because in FRCS ophthalmology is a comprehensive ophthalmology exam, and all the candidates should know how to manage, including surgical steps, though they are not doing the surgery. So that is what is your expectation would be, the examiner's expectation would be. So you need to know like the nitty-gritties of everything. At least you'll have to read the Kansky, and Kansky should be read at least 4 or 5 times.
Yeah.
Dr. I think just ask the spot diagnosis so that they can read and we can get do the mock exam again when they are more prepared.
So this is a picture of a 28-year-old male, optos picture of 28-year-old male with floaters, and history of chest X-ray, he has hilar infiltrates. So what could be the diagnosis?
It's a periphlebitis
Yeah.
and
And-
because of sarcoidosis.
Okay. So this is an important case. One should read periphlebitis, vasculitis, Eels disease, and these are common cases, especially in India. And I think also in other countries, Asian countries also. We should be thorough with this, and also sarcoidosis also. So this is an important case, and this is another fundus picture. 67 years of male. Can anybody describe this and diagnose this picture, please? This is pre-treatment. This is the post-treatment. The left eye is the pre-treatment phase, and right eye is the post-treatment.
So it is a case of mostly toxoplasma.
Yeah, very good. Okay.
Fog and light. Sorry, light and fog.
Yeah. Okay. So this is an important case. You should know. They can give you a picture of only a scar in the retina. So they will ask you. They can ask. Then they will go on asking questions. So this is what do you see in this floating in the vitreous? What is the making the media hazy? What do you call this?
Vitreitis.
Vitreous cells or vitreitis? So actually, this patient has 6/18. He has a drop in vision. But what are the indications of toxoplasma treatment of treatment indications of toxoplasma? You should know in Pansky. What can you tell about any of the drugs? Anybody tell about what are the drugs available for treatment?
Yeah, I can. Okay.
Pyrazinamide, sulfamethoxazole,
Okay.
clindamycin.
Yeah. At least you should be able to, because cotrimoxazole is easily available. You should be able to mention that cotrimoxazole, clindamycin, azithromycin. At least you should be able to tell these three. There are other drugs also, or whichever is available. I don't. In India, I think cotrimoxazole is most easily available. So we treat this with cotrimoxazole mostly as the initial drug of choice. So this Toxoplasma retinochoroid is also very important. You should read thoroughly. So today I am signing off, Dr. Kaushik. So these are the drugs you should know about. Okay, for today, let us end here.
Yes.
Okay.
Excellent presentation, Dr. Angshuman. Very actually, most of the cases can be asked in exam.
Yeah, I actually selected these cases also because these are the usual cases they give. These are the common cases available in our country and also in our OPD. So they can easily ask these questions.
And I'll request all the candidates to please be more sincere because the exam is FRCS is not a very easy exam. So you need to know the like basics very clearly. So definitely I think there is a chance of improvement in preparation in retina.
Actually, in FRCS, one have to do a little of joint study. You should make friends with other candidates and you can study jointly in WhatsApp or Telegram or whatever. mode you can single by singly if you are reading, you mostly most of the times tend to forget. It's easy when you do joint study. You can you can link up with other candidates to a joint study. So there is a lot of lacunae when you're you have to read a lot, especially Kansky. You have to be very thorough. Okay, Dr. Kaushik, we'll sign off for today.
Thank you, thank you, thank you, and we'll conclude.
Okay.
Thanks, Dr. Angshuman. Okay, good day.
Thank you.
Good day. At best wishes to